Hey guys, today we're going to talk about the structure of the hip. So the hip is a really fun joint to learn because there's a lot of muscle attachments, there's a lot going on at the hip, and it becomes a really important part of a lot of sport and exercise movements. But it's important that we first learn all the anatomy and the structures that surround the hip, and then we'll dive into some function and motion in later videos. Let's take a look at the bones first. So when we think of the hip joint, a lot of times we think of kind of where that femur or thigh bone attaches to the torso or the body, but there's really a lot of bones and areas that are worth mentioning in the hip and pelvis area. So let's start with the posterior side of the pelvis and SI joint area. So if you recall from the spine video, the sacrum is this bone that's kind of that continuation of the spine in the middle here, and the sacrum meets this ilium bone here, which is a part of the pelvis, to form the SI joint or sacroiliac joint on both sides here. Okay, so this whole area is the ilium portion of the pelvis. There's a couple important points that we should mention on the ilium. This top crest is the iliac crest, and then more anteriorly we have the anterior superior iliac spine and then the anterior inferior iliac spine. These are usually referred to as the ASIS and the AIIS. These two are really important attachment sites for some of the hip flexors and some of the rotators of the hip. Okay, we'll talk a bit more about that in the function video. As we move anteriorly, we can see the pubis portion of the pelvis, which is kind of this most anterior portion. People call it like their pubic bone or their pelvic bone, right here. And where these two pubic bones meet is called the pubic symphysis. That's an important point to know too. That's central right here. Okay, and then posteriorly, we have the ischium. Okay, so that's kind of this posterior portion of the pelvis here, with these 2 points being the ischial tuberosities. So that's an attachment site for the hamstring muscles, and it's kind of, when people mention their sit bones or the bones that they're sitting on, that's kind of what they mean by that. Okay, so that's kind of the main osteology points of the pelvis itself. We could get a little bit more specific there if we want to, but for what we're mentioning now, that's really all we're going to stick to. Okay, let's move on to the femur. Okay, so I'll use both of these models to kind of explain this. The femur is obviously our thigh bone. Okay, it attaches into the pelvis at the acetabulum. Okay, I'll have you zoom in here. The acetabulum is this kind of cup, and the femur head sits inside of there. Okay, so it's very similar to the shoulder. If you remember how we had described how there's a labrum in the shoulder and it kind of protects and acts as a suction cup for the arm, I want you to think of the labrum of the hip in a very similar way. Okay, so inside the acetabulum is that labrum that holds the head of the femur in. Okay, when we take a look at the head of the femur on the board, we notice that again it's lined with our hyaline cartilage just like our shoulder, and it kind of fits into the pelvis. Okay, so the part that actually makes contact with the pelvis and the acetabulum is the head of the femur right here, and then the neck of the femur is kind of the bridge between the head and the rest of the shaft of the femur. So that's this area right here. And then the two main points proximally on the femur that we want to be aware of are the greater trochanter up top and the lesser trochanter at the bottom. The greater trochanter up top is an important site for some of our hip rotators, and the lesser trochanter is an important attachment site for some of our hip flexors. Okay, so now that we have a little bit better idea of the bones that go into the pelvis and hip, let's take a look at some of the nerves, arteries, and veins. So when it comes to the lower extremity, we obviously have a ton of big muscles and a lot of structures that need adequate blood flow as well as adequate nerve supply. So we'll talk about some of the structures that provide that here. All right, so we'll start with the blood flow. All right, so we have the descending thoracic aorta coming down inferiorly. That splits into the common iliac artery on this side. The common iliac artery then splits into the internal iliac artery and the external iliac artery. The internal iliac artery goes to the greater and lesser sciatic foramen more posteriorly, as well as to the obturator foramen anteriorly. The external iliac artery continues down the leg and becomes the femoral artery here in red. Okay, so once it passes about the level of the ASIS, the inguinal ligament area, it becomes the femoral artery. Okay, now obviously we brought blood down to the leg and thigh now. We need to bring blood back to the heart. Okay, the main vein that does that is the femoral vein, which is located right next to the femoral artery, but it's a little bit smaller in comparison. Okay, so that's kind of the blood supply surrounding the hip. Now let's talk about the nerve supply at this area, okay? The main nerve supplying, again, motor and sensory function to the hip area is the femoral nerve. It's located right next to the femoral artery, and it arises from levels L2 to L4 in the spine. Okay, so those spinal nerves exit the IVF, form together, all right, and then make the femoral nerve coming anteriorly, okay? Anatomists refer to this area, the hip, as the femoral triangle. There's a couple other structures that we won't cover today, but just know that these three are the main structures of the femoral triangle, okay? The other nerve I want to mention is the sciatic nerve, okay? So let's look at the pelvis from the posterior aspect. Okay, so we have the sacrum, the ilium, and the lumbar spine. The sciatic nerve arises from the levels L4 to S3. Okay, so that's from about here to here, and the spinal nerves will exit either the sacral foramen here or the IVFs here and form together the big sciatic nerve, okay, coming inferiorly. Okay, it's a very large nerve. It's very easy to see on cadaver studies, and it's a common nerve that gets injured in a lot of desk workers and really just the everyday person. That kind of produces some of those numbness and tingling symptoms, that sciatica, syndrome or whatever you want to call it. But remember that the sciatic nerve also has motor function to a lot of the musculature in this area as well. Okay, so that's a common one to understand its location of. We'll talk about some of the musculature in some future videos, but that's kind of the main nerve coming down the posterior aspect of the pelvis. So the next set of structures I want to talk about are the ligamentous structures of the hip and pelvis area. So remember that the ligaments typically attach bone to bone, and they prevent motion of those bones in certain directions. Okay, so let's take a look. The first one I want to mention isn't necessarily a ligament. It's more a cartilaginous structure, but it sort of acts like a ligament, and that's the pubic symphysis. Okay, so it attaches the two pubic bones and prevents excessive spreading of the pubic bones out laterally. Okay, as we move out laterally to the femoral head, we have a couple really important structures that I want to make sure you understand. The first is the ligamentum teres. Okay, so this attaches the head of the femur into the acetabulum. Okay, so that's another structure that's kind of holding that femoral head in place. And an interesting note here is that the artery to the head of the femur, which is actually the name of the artery, supplies some blood flow to the head of the femur here, and it's kind of located within that ligamentum teres. Okay, now we also have a couple circumflex arteries that come back off the femoral artery to supply blood to the head of the femur, and so that's worth noting. Kind of a side note here, if you recall Bo Jackson's injury from years ago, he actually dislocated his hip itself and tore through some of those arteries, which led to an avascular necrosis happening of his femoral head, which eventually ended up with him stopping his playing career as well as needing a hip replacement. So these arteries are vitally important to the health of the hip in general. Okay, so that's important to know. All right. The other ligamentous structures in this area, there's three that connect the pelvis to the femur. We have the iliofemoral, the pubofemoral, and then posteriorly we have the ischiofemoral. Okay, those ligaments again provide more stability of the pelvis and femur, and they prevent excessive hyperextension as well as excessive hyperabduction, so the leg coming out here. So they kind of hold the femur in place. Okay, as we look posteriorly, again we'll use our model for this. The two structures that I want to mention here are the sacrospinous ligament, okay, which attaches from the sacrum to the ischial spine, as well as the sacrotuberous ligament. So again, from the sacrum to the ischial tuberosity. These two ligaments are kind of orientated like this, and they prevent excessive rotation of the ilium on the sacrum. So, okay, so again, kind of holding things in place is the job of these two ligaments here. Okay. So now that we understand some ligaments, let's move on to some structural considerations of the hip. So there's two main structural considerations that I want to talk about when it comes to the hip today. The first is femoral acetabular impingement, and the second is anteroversion and retroversion of the hip. So let's start with FAI, or femoral acetabular impingement. Okay, so there's two types of FAI. There's a cam deformity, which is essentially a bony outgrowth of the femoral neck area that kind of runs into the pelvis, for lack of a better term, or there's a pincer deformity, which is the pelvis having a bony outgrowth right around here, which kind of impinges over the femoral neck. Okay, so you can see that either way, we're kind of getting a bone-on-bone occurrence happening here, and that can cause some pain and limited range of motion in people. It should be noted that it's not always, just because you see that on x-ray, it doesn't always mean you're going to have pain or dysfunction, but it's something worth noting, okay? The other thing I want to talk about is anteroversion and retroversion of the hip. So that refers to the angle at which the femoral neck kind of exits the pelvis. If that angle is acute, like this, okay, you'll see a little bit of reduced range of motion and things like that, but it's still considered relatively normal, okay? And if that angle is obtuse, you might have kind of a toed out position, and again, some missing range of motion, a little bit of dysfunction, but it's still considered normal. These are all anatomical variants, and they exist on a spectrum, okay? Obviously, way too much in one direction could cause issues, but you know, if you were to survey 100 people, you'd see 100 different femoral angles, and that's considered normal, okay? So those are the main structural considerations that I wanted to teach you today. If you liked the video, make sure you check out our other Biomechanics series video and tune in for our function and motion video coming soon, and we'll see you in the next video.